Now let's examine the dissociative drugs, particularly PCP and ketamine. Both PCP and ketamine share a similar mechanism of action. They're both NMDA receptor antagonists. Basically what happens here is that when ketamine binds to the NMDA receptors, we can see less GABA release, shown here in light blue. That then causes more glutamate release onto the red neuron, which is shown here in black and blue. And then this red neuron then has an increased amount of dopamine release, shown here in red. So the depression of glutamate activity in the cortex and thalamus then stimulates the limbic system by inhibiting NMDA receptors on GABA interneurons. And so this is your GABA interneuron. And remember, the GABA, of course, is the inhibitory neurotransmitter. In terms of the kinetic profiles of PCP and ketamine, these drugs have significant first-pass metabolism. They rapidly cross the blood-brain barrier, and they have long-lasting effects. Very low doses can produce disinhibition and giddiness. Moderate doses, you can see distortions in space and time, psychotic reactions, including panic, catatonia, even paranoia for some patients. Here you can see the beginning of the anesthetic and analgesic effects. At high doses, you've got basically a model of acute schizophrenia that can last for about a week. Some of these patients turn to be violent and they can be combative or abusive. With chronic use, you can see long-lasting psychosis that really resembles schizophrenia for a lot of these patients. In terms of the intoxication profile for these drugs, you can see anxiety, chest pain, palpitations. There will be some amnesia. The pupils will be moderately dilated. There will be increased muscle tone, and there'll be an absence-like type of effect. So the patient appears awake, but they're unresponsive to cues. Treatments, typically we give benzodiazepines for the agitation and supportive care.